Open surgical domain.
So we got a little debate about open surgical and bringing open surgery, trying to defend open surgery at this meeting. It's a bit like bringing coal to Newcastle. But here's the disclosures again, and again, there's room on this trial. We meet again, and I just want to say at the outset that I have the deepest respect and include me among Dr. McKenzie's great admirers. However, when we're going to be looking at some of this information, I think it depends upon the definition and how some of these definitions are applied. When you talk about hybrid arch classification, in this thing from Chad Hughes, there were 8 types. But if you look at the one on the right there at the top, I mean, that's a sternotomy. So is that hybrid? And then the sternotomy and on pump. So I think the definition of hybrid is not in the literature precisely defined. I think we need to take that into consideration. And here's the other definition of the original 3 types out of the Penn group with this type 3. Basically is a total arch replacement. It's a frozen elephant trunk. The Thoraflex is called a Thoraflex hybrid device, but actually it's a total arch replacement. And the hybrid part is really almost secondary. Dr. Provenza showed this, but I think as the anatomy here can be very variable. It's also, as has been pointed out, a very dynamic structure. So this all needs to be taken into consideration. This can be managed open quite easily in almost all these cases, but endovascularly, we're going to have a lot of flexibility. Dr. Provenza showed us this as well. Our arch aneurysm pathology is rarely an isolated phenomenon. We have quite a number of tools in our chest for open surgery, and we can manage almost any pathology. It's the condition of some of the patients which are difficult to manage. So what do the guidelines show us? So this is, I'm going to talk about EACTS, Mezzaloni, and Isselbacher, and throw them all together. So if they're symptomatic, open operations recommended. It's class 1 recommendation, so let's get over that part. With regards to asymptomatic, if it's asymptomatic and it's greater than 5.5 millimeters, it should be considered. That's not a green one. Those are 2A and 2B. And then with regards to if they're unsuitable for open surgery, which is certainly in high-risk patients, hybrid or endovascular should be considered. And again, these are not green. These are not number 1 recommendations, and the level of evidence is not terrific. And I'll just throw this in because we've been talking about it. If the disease extends into the proximal descending thoracic aorta, frozen elephant trunk is not a class 1 recommendation. It's a 2A. And part of that's based on the fact that paraplegia is not entirely absent. So this is a meta-analysis of a couple of thousand plus patients of open repair. So what are the results of open repair? What are we seeing out there? Well, in elective cases, the mortality can be around 3% and stroke about 2.2%. That's actually not too bad. So this is some open total arch replacements in series that have over 400 patients, because you can do, reports of 50 or 60 patients can swing either way. So these all have over 400. So if you look at the results, spinal cord problems are very, very rare. Renal problems are not insignificant, but the 30-day in hospital mortality is about 5% roughly. DeMarco is a little bit of an outliner. I'm not against hybrid. This is a case that we did. This is another case. This is a case that we debranching and then placed a stent across it. So we don't do as much as we used to, but I'm not against it. This is a patient that had a sternal tumor that was resected and replaced with this methyl methacrylate, which then encroached upon the arch. This was included in a paper that Dr. Provenza put together, and the results of those 29 patients that we did, only 2 patients died in the hospital, and strokes were not insignificant, but only one had an extensive stroke. The other 2 were minor, and their paraplegia was 0. They did have some other issues, atrial fibrillation, some endoleaks. Aortic reintervention was 2, but the renal insufficiency and retrograde dissection was 0. So this is what we did to that patient. This is actually in the paper that she wrote, and it was just we went a little small incision in the left chest, debranched everything, and then put a stent graft across it. That patient was doing well 10 years later. Hybrids do have complications. They've got endoleaks, they've got retrograde aortic dissection problems, stent fracturing, stent migration. It goes on. And on. So how do these hybrids versus open do? Well, the STS database for open TR looks at a mortality rate of 6.7% and stroke of 6.9%. 9%, but if you look at the hybrid, it's actually a little bit higher out of the STS database. And so this is what real-world experience is with lots of people contributing to the data rather than just a few institutions of high volume. This is a meta-analysis of a little less than 10,000 hybrid repairs, and stroke was not insignificant, but it's particularly high in zone 0, and the 30-day mortality rate was 9%. This is my own work. This is 3,398 arch operations up through February of this year, so it's pretty much up to date. The average age is about 63. A lot of these patients had heritable thoracic disease. Chronic dissection is 20%. Interestingly, rupture, and albeit all these are contained ruptures, but that was 87%. A lot of these patients had coronary and kidney disease. Albeit a lot of these were hemi-arch replacements, but 826 were total arch replacements, with 379 being elephant trunks, and frozen elephant trunk with Helmater investigational device was 214. We did emergent repairs in about a third of these patients. A third of them had redo median sternotomies, and we did root replacements in a quarter of the patients and coronary bypass grafts in about 1 out of 5. So the operative mortality was 13%. But if you look at elective, and these are elective all-comers, so they're elective, but they're just not ruptured and immediate operations. And persistent stroke was 2.7%, and paraplegia was 0.1%. We are in an endovascular era. That goes back to bringing Coles to Newcastle, and we've heard a lot about this. We're getting ready to hear some more with Dr. McKenzie. But there's a lot of options here. It's under development. It's important. We all have to keep in mind. You're all familiar with this ART stent graft history as things go, and this is a continuum, and I'm sure AI is going to contribute to a lot of this. But endovascular complications, I mean, there's strokes and occlusions and endoleaks, infections and paraplegia, and et cetera, et cetera. So just this thing is not advancing. It just died.
Keep going.
Can I go back? I've just got a couple more slides.
Should go back.
It's not responding.
They're fixing it, hopefully.
I will tell you, I've told the perfusionists who are not doing what I ask them to do sometimes that they're going to be replaced by AI. Siri, could you bring the pump flow from 5 to 5.5 for me, please? And they're done.
Yeah.
So here's a total arch endovascular case that we did. I believe Dr. Provenza helped us with this, and this is a couple of this is the same thing you've seen with the debranching of the carotid subclavian and then grafts placed across there. This patient had a nice landing zone proximally. So in 15 studies with 273 patients in this particular report, the mortality for these endovascular repairs, total endovascular arches, was 15%, and stroke 14%. And this is Basha from the Canadian group. And they use double branch in 70% of these, triple in 20%, but only a single branch in 10%. So these are real endovascular arch repairs and kind of real world data. So from the conclusion, open surgical repair is a gold standard based on the guidelines and provides a durable repair. Open surgery offers superior visibility, control for handling, and dealing with the variability in anatomy that I mentioned earlier. And the guidelines for Europe and the USA, and even the Vascular Society, still endorse open surgical repair for most of these, although it does recognize that technology has to keep moving. And hybrid endovascular techniques still pose significant risks, including retrograde dissections, stroke, and endoleak. And I certainly wouldn't be one to stand in the way of suggesting that all of these problems and complications of the endovascular devices aren't going to be solved as we continue to push the envelope. So I think Jim and I are going to have a lot of agreement. We're going to have low physiological risk and high complex anatomy is probably ideal for open. But if they have high physiologic risk and complex anatomy, et cetera, that there's so high risk, low complexity, ideal for endovascular. If it's high in both circumstances, probably they're ideal for either endo or a hybrid approach. And I think we're going to probably have a lot of overlap in our thinking of this. Thank you very much.